Hello, hello. Hi, and welcome. Thank you for joining me. We are going to get started in just a brief moment. Give another second. I'm excited for the information that we're going to go over tonight. This is part 2 in a series. And if you missed part 1, we have the replay link available for you. And so I will send that out with the replay link for this video as well. So yeah. Well, let's go ahead and get started. I'm going to share my screen. All right. Okay, hopefully you can see that. Are we all good? So hi, and welcome to New Frontiers in Lyme Treatment, updates on emerging and adjunctive medications. So my name, for those of you that don't know me, I am Dr. Nicola Ducharme. I am a Lyme literate naturopathic doctor. I'm the owner and medical director of Restore Medicine, and we are an integrative medicine clinic based in San Diego, California. I work with patients all over the place. I am licensed in both California and Arizona, which means I have full prescriptive authority in those states. I do work with patients out of state that can't necessarily prescribe out of state. So primarily doing advising, getting testing going, putting together treatment protocols with people who are working with their local doctor. So just a disclaimer before we get started, this presentation is for informational and educational purposes only and does not constitute medical advice. The content presented is not intended to diagnose, treat, cure, or prevent any disease. Always consult with your qualified healthcare provider before making any changes to your medical care or treatment plan. Okay, so as I mentioned, this is a 2-part series. In part 1, we went over some sort of emerging medications, not necessarily new medications, but maybe newer in their use in their context of Lyme. So we talked about ivermectin. We talked about piperacillin, which isn't really available for Lyme yet, but has some promising potential for the future. We talked about tafenoquine for babesia, methylene blue as an antimicrobial, a neuroprotective, an antioxidant, a jack of all trades medication, and then dapsone addressing persister cells and disrupting biofilm. So that happened last month. It is on YouTube if you want to go find it. And I will also try and remember to send out the replay link to after this webinar as well. So that was last month. This is part 2. So I'm looking at other notable treatments, so not necessarily in the sort of standard antibiotic categories, but things that I am using in my practice and seeing really good results with. So low-dose naltrexone, also known as LDN, I'm going to talk a little bit about that, not too much in too much length. LDN has been around for a while, but it is a solid citizen. Its benefit is mostly in immune modulation, but we will talk through mechanisms of that and how that works. We're also going to talk about the GLP-1 agonists like semaglutide, tirzepatide. This is really exciting to me. So I'm working with a number of my patients with these compounds, with these peptides, and seeing amazing things. I mean, on label, we think of it for weight loss and metabolic control, but it's showing some great promise for like neuroinflammation. So we're going to talk about the ins and outs of those. And then also SOT therapy, which has been renamed Q-Restrain, which is a gene silencing therapy. And that's fascinating. And we're seeing some really good things with that too. So it's more like a targeted antimicrobial. SOT is custom designed to inhibit pathogen replication. So I'll talk to you through how that works and the process of SOT therapy as well. Alrighty, so let's start with low-dose naltrexone, or LDN. So naltrexone as a medication was originally approved in higher doses, like 50 to 300 milligrams, for opioid addiction. So it was used to help people get off like morphine and heroin and things like that. I've also seen it be used more recently for helping people with alcohol cravings at a dose of about 50 milligrams per day. But it was doing that by sort of blocking the opiate receptors in the brain. And so it's been used for that for a very long time. What researchers found is at low doses, it acts as an immune modulator. So it's not an immune suppressant like a steroid would be. So most of the time, my general school of thought would be steroids are not great for Lyme patients. Like we don't want to suppress immune function, right? Even if a steroid may help somebody to feel better because it is dampening inflammation, it's also suppressing immune function. And when we're fighting chronic infections, we want our immune system working. Now, there are times where I've done short courses of steroids where that's appropriate, or localized steroids, like a steroid injection in a joint, for example. However, the broad school of thought is steroids are not optimal for people with chronic infection. LDN is not an immune suppressant. And it's an immune modulator, meaning it balances immune function. If the immune system is like hyperactive and with that autoimmune kind of stuff going on, it can help to bring that down. If the immune system is low and weakened, which is often the case in chronic Lyme, then it can help strengthen it. So it's a really nice kind of balancer. Dosing, I'll talk a little bit more about in a second, but typically 1.5 to 4.5 milligrams is the kind of ideal range. In low dose naltrexone, I don't dose higher than 4.5 milligrams. That's the upper limit of the low dose category. So LDN helps to rebalance immune function. So very helpful in autoimmune disease. And there's quite a lot of research on LDN with various autoimmune conditions. Now, of course, one can have Lyme and have an autoimmune disease. One can have an autoimmune disease and not have Lyme. But I do see that there are cases where Lyme and chronic infections trigger autoimmunity in the body. So we might see a positive ANA, we might see, antibodies in Hashimoto's thyroiditis, signs that there is autoimmune process going on. But sometimes with these positive ANAs, they don't go on to then test positive for like lupus markers or Sjogren's markers, for example. So it's kind of like this vague autoimmune signal. And I have seen that go from positive to negative with Lyme treatment. So we know that Lyme can trigger an autoimmune kind of process. So very helpful in chronic infections, so Lyme pathogens, and also in inflammatory syndromes for reasons that I will talk about in a second, but just by rebalancing immune function as well can help with that inflammatory cascade. So conditions LDN may help. I've read any condition involving immune dysregulation may benefit from LDN. So Lyme is an obvious one. Fibromyalgia, and chronic fatigue, which are obviously like syndromes, can have mixed etiology, but nonetheless, in both the immune system is dysregulated. Hashimoto's thyroiditis, which obviously has that autoimmune component. Rheumatoid arthritis, Crohn's. I've used this a lot with kids on the autism spectrum. And it's more for that, it is the immune regulation, but it's also the benefit to the endorphins, which I'll explain in a second, that can be really helpful for like behavior, cognitive function, etc. So how does LDN work? So I mentioned that it's historically was used for getting people off like opiate drugs at higher doses. Well, what the LDN is doing, the low dose naltrexone, is it has a very mild binding effect with those opioid receptors. So we all have opioid receptors in our brain. And so rather than like heavy binding and blocking the receptors, it has a mild binding effect with the receptors. And that causes the body to respond differently. It causes the body to upregulate natural production of enkephalins and endorphins. Okay, so the enkephalins are those immune modulating chemicals that, with the benefits that I've been talking about, can strengthen a weakened immune system or dampen a dysregulated immune function, aka autoimmunity. So that's the enkephalin part of the upregulation in our brain. As I said, it works as a balancer. It's not a stimulant. It's not an immune suppressant. It can reduce inflammation. It can enhance immune surveillance. It can help regulate immune suppression caused by tick-borne pathogens. And we are seeing more and more, it may help with mast cell activation syndrome. So I'm seeing more MCAS, or mast cell activation syndrome, in my patients. We know that Lyme is a massive trigger for MCAS. We know that mold is a massive trigger for MCAS. And LDN, it's not what I would consider like a first line therapy, but it's something I definitely consider part of my toolkit for mast cell, just by helping to regulate those wacky immune responses. So then the endorphins are the other group of chemicals, right? So we have our enkephalins, our immune balancing, and then we have endorphins, which are our feel-good chemicals. So endorphins can do a few things to be helpful: reduce pain, improve sleep, increase energy, and improve mood. So when I say to a Lyme patient, okay, LDN has the potential to help with pain, sleep, energy, and mood, there's not many that are like, oh, no, thanks. I don't really need that. I don't really want that. Everyone's like, yeah, sign me up. So LDN does not work for everybody, but it does have the potential to help with these certain symptoms. So lots of benefits here. Helping sleep quality, and as we'll talk about in a minute, temporary sleep disturbance was one of the side effects that I was observing with LDN in the beginning. I've kind of found ways to get around that, so that's helpful. Reducing pain just by, having those extra endorphins running around and moderating the inflammatory response are both helpful for reducing pain. Increasing energy in and of itself, but also as a byproduct of having better sleep quality. And like I said, helping regulate immune suppression and a more balanced immune response. So lots of potential benefits there. Now, typically, I find LDN to be pretty well tolerated. Okay, and I know there's going to be somebody out there that's like, oh, not me. I got dizzy and I felt weird, and like I've had a handful of those. I have had a handful of those, but it's been a small group over the years for how much I've prescribed it and how, like, relative to other interventions and their potential for side effects, I view LDN as like fairly low on the risk/side effect side of things. So probably the first thing I saw was usually early in treatment with LDN and usually fairly mild. I did have some cases where they were like, I tried to get through it, but couldn't. The sleep disturbance kind of was too much, and that patient had to go off LDN and kind of give up on it. But that is one of the things that I have seen. Now, like I said, I've had a handful of patients over the years who have reported something worse, like bad cases of dizziness, off balance, emotional kind of like dysregulation, maybe too strong of a word, but just kind of feeling off. But it's been much, much, much less than a lot of other interventions, which is kind of what I like about LDN, because I do think it has a good safety profile. Cautions would be in Hashimoto's. So if you're going to improve somebody's autoimmune status and improve potentially their thyroid function, we need to then monitor medication doses and make sure that their thyroid hormone dose is still appropriate if they have improvement in their thyroid function. So that's kind of like a good side effect in a way, but still something to be watchful of. It's contraindicated in patients using narcotic pain medications. So that is one thing that's really important. And that is a hard no. That is a hard contraindication. They'll be competing for the same receptors. So we just don't use those together. And avoid in transplant recipients, but that's pretty true of any immune modulator or anything that's going to impact immune function, because obviously transplant recipients are busy trying to suppress, rejection and things like that. So we don't want to monkey with that by any stretch, but relatively few absolute contraindications. Oh, and by the way, I meant to say this at the beginning. We'll likely have time for questions at the end. So if you have a question or a comment, just pop it either in the chat or the Q&A. And then at the very end, I will try to address as many questions as I can. Okay, so LDN, not everyone responds equally. I guess that was important enough that I felt it deserved capital letters. But that is kind of the bottom line with LDN. It works beautifully for some people and just not at all for others. And so the people who do well on it love it. And I mean, I will say there have been people who've come back and went, oh, that was a game changer. Like that was really, truly like life-changing. And then some people come back to me after a month and go, meh, you know, and after a month or maybe two, if there's no improvement, I don't continue. So it's mixed. And so, you know, there's no one thing that works for everyone, right? Wish there was. So I think it's worth a 2-month trial, say 30 to 60 day trial. It's not crazy expensive. So when I prescribe LDN, we'll talk about dosing in a minute. The first month is more expensive because I prescribe a higher quantity of a lower dose so that we can start lower and titrate up. Once people settle into their dose, it's usually about 50 a month. Different compounding pharmacies are different, but that's kind of what I have found as a bit of an average. So the people it works for love it. It can be a game changer. It's just not for everybody, unfortunately. So LDN is compounded. So you won't find LDN through a regular pharmacy. It is definitely a prescription. I have tended to avoid sustained release formulations, avoiding calcium carbonate as a filler. Both those things can reduce the efficacy of the medication. So dosing strategy for LDN. So one thing that I've learned is when I started my patients at 4.5 milligrams straight off the bat, that's when I saw more of that sleep disturbance. And even though usually it was mild and usually it was temporary, if we can avoid it, so much the better. So now I start everybody, well, not everybody, my average dose people, like my not super duper sensitive folks, I will typically start at 1.5 milligrams. It's taken at night before bed. And that's really because the immune system kind of turns on and does its housekeeping at night. And also just for the sleep benefits of it. I have had some folks that had to end up shifting and doing the dosing in the morning if it was disturbing their sleep, but if they took it in the morning, it was fine. So that was, you know, that was a worthwhile trade-off. But typically 1.5 milligrams, I do that for a few nights, then increase to 3 milligrams, do that for a few nights, and then go up to 4.5 milligrams. And that has really prevented that temporary sleep disturbance. Is doing it that way. Now, if I have more sensitive people, sometimes I'll start at like 0.5 milligrams or even 0.25. But generally speaking, most people can do the 1.5 and go from there. Some people do feel better at a lower dose. So I've had patients who are like, okay, I went from 1.5 to 3 and that was okay. And that actually was helping. But then I went to 4.5 and I didn't feel as good. And I'm like, okay, great. Then your dose is 3 milligrams. And so we just want to stick with the dose that gives the best results. More is not always better in this case. And we are all individual. So if a lower dose works better, I've had some patients that started at 0.5 who are really sensitive. They might have worked up to 1 milligram. That might be their capacity. So that's what they do. And that's fine. So LDN offers a safe, affordable, and low-risk option. Like I said, the side effect profile, the risk profile in my view, is pretty low in the grand scheme of things. It balances and modulates the immune function without overstimulating and potentially could relieve pain, fatigue, inflammation, and poor immune regulation and help with sleep and energy. So nice potential there. And in my view, kind of worth a try. Very useful in chronic complex conditions like Lyme, mold, and mast cell activation syndrome, and worth exploring as part of a comprehensive treatment plan. So there's no one thing that's the thing, but this is something that I think has a lot of value. right, so let's talk about GLP-1 agonists. I'm going to talk about semaglutide and tirzepatide because they're the two peptides that I've had experience with. I understand there's, newer generations coming out, and it will be interesting and exciting to see where that leads. But I'm going to talk about the ones that I've had access to for my patients and what I have seen there. So first of all, what are GLP-1 agonists? I think most of us have heard of them by now because it's all over the media and all over social media and all the things. But really, they're peptides. So peptides are strings of amino acids. So how I describe it is an amino acid, think of a pearl necklace, right? An amino acid is a single pearl, just one little pearl sitting by itself. A protein is the whole necklace. A peptide is a string of pearls strung together in a particular order. Okay, and they may be different size peptides and different configurations of peptides, but essentially peptides are strings of amino acids that have a function in the body. So we have this glucagon-like peptide, this GLP, is a naturally occurring hormone in the body. The difference is ours, the naturally occurring form, breaks down super quickly, and the compound or the medications, let me say, whether they're compounded or commercial or whatever, are just slightly adjusted forms of the peptide so that they last for longer and stay active for longer in the body. So because they're naturally occurring, we have receptors for this hormone through the body and in the brain. So that's where we're seeing some of the widespread benefits over and above just weight loss. So, of course, initially used for diabetes and weight loss, and probably best known for that even now, but they are getting recognized for broader systemic benefits, and I'm certainly seeing that in my patients. So GLP-1 agonists just enhance the GLP-1, like semaglutide is a GLP-1 agonist. Then we have dual agonists that have dual action on GIP and GLP-1 receptors. GIP is glucose-dependent insulinotropic polypeptide. So long word for that. So let's call semaglutide was like the first generation of GLP-1s. Tirzepatide was kind of like the second generation. I will say tirzepatide may, in some cases, have better weight loss effects, potentially maybe better glycemic control. However, in my case, in my practice where I'm using mostly the compounded medications and where I am located in the state of California, tirzepatide is just much more challenging to get. So I'll talk a little bit about some of the laws and the restrictions, but I, as of right now, cannot get tirzepatide shipped directly into California. Anyone in California has to have somebody out of state to ship it onto them. Whereas semaglutide, I can get shipped directly into California from the compounding pharmacy that I use, but a little bit more on that in a minute. So when I started using GLP-1s with my patients, tirzepatide was not available at all as a compounded. So I started using the semaglutide. Therefore, the majority of my patients, probably 90%, are using semaglutide over tirzepatide. Is that necessarily because it's better? No, it's more because that's what we could get and that's what we have access to. So how GLP-1 agonists work? So from like a weight loss / metabolic regulation standpoint, they improve blood sugar control by enhancing insulin secretion and inhibiting glucagon release. They help weight loss by slowing gastric emptying and promoting feelings of fullness and satiety. So the GLP-1s, when we're talking about weight loss and diabetes and pre-diabetes and things like that, act in a number of different ways. So they do help you feel more full for longer. So you're just not going hungry and looking for food as quickly as before. They do slow the transit through the digestive system. Now, sometimes people can get some constipation through that. Like everything does take longer to go through. You hear these horror stories about like gastroparesis, where the whole digestive system just shut down. I mean, I'm not here to argue for or against side effects. I have not had anything major like that happen to my patients. I have had some side effects, digestive side effects in my patients that I'll talk about. But so the GLP-1s do slow gastric emptying. They promote feelings of fullness. And so you just don't get hungry, and you get full quicker and don't get hungry as fast. So that's sort of one of the bottom lines. But they do improve blood sugar control. And so I have some patients that like really had difficulties regulating blood sugar, not necessarily with a weight issue attached, just a blood sugar regulation issue. The GLPs have really helped that too. There's a reduced risk of hypoglycemia. So the GLP-1s stimulate insulin release when blood glucose is elevated, keeping blood sugar levels more stable. They also work on the part of the brain responsible for appetite and metabolism. So you've got a few different like mechanisms here that, in terms of how GLP agonists work when we're talking about weight loss and metabolic regulation. So I'm seeing that these compounds, these peptides, do promote overall metabolic health. And you can enhance metabolic health without someone losing weight. So that's one thing I'd say is you don't have to be a weight loss candidate to benefit from these peptides. We'll talk about that a little bit more. So then we have these other effects that have been really, really helpful. So effects on joint pain and overall inflammation. So these GLP-1 agonists are acting as anti-inflammatories in the body. And that benefit can happen even at really low doses. So I'll talk about the difference between, quote unquote, microdosing and low dose. And we'll talk about dosing strategies in a few minutes. But I have definitely seen an anti-inflammatory benefit of these compounds, and even at low doses. The other thing, obviously, is if people are carrying excess weight, then reducing that weight can take some of the strain off the musculoskeletal system. So I have seen that too, but it's not just that. It's so much more than that. So we are seeing significant anti-inflammatory effects, both in the body and in terms of neuroinflammation. We're also seeing cardiovascular benefits, reducing the risk of strokes, heart attacks. There's more and more research coming out about that. These peptides may be neuroprotective. So I was reading some articles about prevention of Alzheimer's and dementia and some of those like neurodegenerative diseases. But how this really impacts my patients is I'm seeing a tremendous benefit, like with mental clarity, helping with brain fog, like the Lyme brain, that kind of thing. And there is potential for long-term use. Studies indicate that semaglutide and tirzepatide are effective over extended periods, suggesting that it can be part of a long-term treatment strategy for many individuals. Now, a lot of people ask me the same question. Oh, am I going to be stuck being on it forever? No, you're not. You're not stuck being on anything forever. I have had patients and friends and people I know who have done GLP-1s for a period of time and then weaned off. So we either for that, titrate down the dosing ladder. I'm going to show you the dosing ladder in a minute. We can space the injections out more frequently. Their standard is weekly subcutaneous injections. So then some people would space out to like maybe every 10 days, something like that. So depending on the dose that one is at, if one has like built up some of the dosing increments, then I don't necessarily just cold turkey take them off it. We sort of go back down that dosing ladder. But when people are concerned that then they're going to be committed to that for the rest of their lives, that's not necessarily true. Now, I will say this, and I admit this to my patients, like I have been using semaglutide for a couple of years. I love it. I feel great on it. And I will happily do semaglutide for the rest of my life to get this benefit. And by the grace of God, I don't have symptoms of chronic illness like Lyme and things like that, but just in terms of energy, overall well-being, managing weight, and just freedom from constantly thinking about food and nutrition and am I doing the right thing? Am I eating the right thing? And I know some of us get into a little bit that restrictive thinking around nutrition, especially when we're trying to be healthy and we're trying to like do the gluten-free and do the low carb or whatever it is. But sometimes that, how do I want to say this? It feels like a little bit of a trap sometimes. And so for me personally, the GLP-1s have really given me freedom from that. And so now I don't have to worry so much in my head. I choose to eat good things. I don't think twice about it. And there's no feeling of deprivation of like what I'm choosing not to eat. So that's kind of nice and kind of freeing. So why GLP-1s are helpful in chronic illness, to address the metabolic dysfunction caused by chronic infections and toxic exposures. I have so many patients who are doing all the right things. They're eating clean, they're gluten-free, they're eating like an anti-inflammatory diet. They're moving their bodies as much as they can, and their metabolism just goes to pot, right? So, and there's all this unexplained weight gain and inability to lose weight despite doing all the things. And that is the perfect situation for the GLP-1s. They help to regulate the cravings, help curb compulsive eating, food addiction. I remember a friend of mine who started a GLP-1 and had only done one injection. And so it was way too early to see weight loss or anything. But she came to me a few days later and she's like, oh my God, is this how normal people are around food? And I was like, oh, what do you mean? And she's like, the cookies aren't calling to me after dinner. Like I can happily just eat on my plate till I'm full and I don't care about, the deprivation of not eating the whole plate. And it was really interesting. And so she was just at the very first week of the very lowest increment dosing and was already getting benefit, even though from a weight loss standpoint, like nothing had changed yet. So I see a lot of that. And the expression I love is it quiets the food noise. So that little chatter about, that cookie is calling for me, or even the chatter about like trying to eat more healthy ways, right? Sometimes that can provoke a feeling of deprivation or a feeling of like kind of a loss of control, if you will. I've talked to patients a lot about this over the years. So this can really help heal that relationship with food and just allow you to eat more healthy, more anti-inflammatory, more nutritious without feeling deprived and without the little voice in your head saying, but I should be able to have that, ice cream, or why can't I have that donut? And so I found that to be really, really helpful as well. It kind of typically has people wanting to eat more healthfully. I've also heard definite reports of people whose cravings went down as well, cravings for alcohol. Somebody, not a patient of mine, because I will say my patient population that actually smokes cigarettes is very, very, very minuscule. But somebody who was a smoker that was able to quit smoking. So yeah, lots of good stuff there. So I do see it reducing systemic and neuroinflammation, so whole body inflammation and inflammation in the brain. And I think that there is what is so valuable to patients with chronic Lyme, that we're always looking for things to help moderate and mediate that inflammation cycle. It can improve mood and brain clarity. So a lot of people have said that, it helps with the Lyme brain and helps them kind of switch on and just feel not so foggy all the time. Can enhance energy, which is also through blood sugar regulation, right? Like without the blood sugar crashes, one's energy is more stable throughout the day. And definitely reduce chronic pain. I talked to a patient just this week who had been on semaglutide for a while, went off it for an international long travel trip, and then was like, oh, I don't know how much it's helping. Let me just go off it and see. And then came back and said, no, it was definitely helping. Like now my joints are more achy, my hands are more stiff. And so we are facilitating getting her back to that. So let's look at a typical dosing schedule. Now this is a guideline, okay? Don't take this as like, this is the way it is. This is a guideline, but typically with the semaglutide, Now, compounding pharmacies, the potency of the medicine, the peptide may change. Okay. So the pharmacy that I'm getting my GLP-1s through now is typically doing a 5 milligram per ml. A pharmacy I used to use here in San Diego did a 5 milligram or a 2.5 milligram. So dosing is always relative to how potent the peptide is, right? Makes sense. So if you're going to have 10 milligrams per ml, that's going to be a very different dosing schedule to 1 milligram per ml. So typical, based on the 5 milligrams per ml, typically we titrate up every month. So it's 4 weeks at a certain dose and then go up from there. So weeks 1 to 4 could be 0.25 milligrams would be about an average. It's 5 units on an insulin syringe. So, I was going to have an insulin syringe here to show you, but an insulin syringe is tiny. It's a very skinny sort of syringe with a very small needle on the end. So usually an insulin syringe is 1 cc, which is the same thing as 1 ml, which is the same thing on an insulin syringe as 100 units. And so we are starting with 5 units. It's like literally maybe a 1/4 inch in the little syringe. It's a very, very small amount of liquid. And I'm always really clear about that. I'm like, I'm not talking about 50 units. I'm talking about 5 units. It's tiny. Weeks 5 to 8 then may go up to 0.5 milligrams. Week 9 to 12 go up to 1 milligram. 13 to 17, 1.5, 18 and onwards, 2.5, which is 50 units. So there are some dosing schedules that go up higher than that. I typically have not needed to go any higher than that. And these are incremental increases that will promote weight loss. So just to be clear, and we'll talk about this more, people who are not looking to lose weight or maybe have 5 pounds or whatever, but more looking for the anti-inflammatory benefit are not going to be doing 20, 40, 50 units. Okay. I can speak from my own experience. I went to 10 units, 20 units, 30 units. I went up to 40 units and actually kind of lost more weight than I should have. And so I backed down to 30 because there gets to a certain point where you don't, it doesn't look good anymore. It doesn't feel good. It's not healthy. So just kind of having that range and the different schedule you just got to be tuned in to what your body's doing and make adjustments along the way. So tirzepatide, and again, there's variances in this, but typically, 2 milligrams. So the one that we can access is 10 milligrams per ml. So 2 milligrams is 0.2 mLs or 20 units, then up to 4 milligrams, 7 milligrams, up to 9, 12, and 15. Now, the nice thing about compounded versus the commercial of these peptides is with compounding, we have the flexibility to choose our dose. And so that's one of the huge differences between compounded GLP-1s and the commercial GLP-1s, other than price and some other variables, is with the commercial, they're pre-filled syringes or pre-filled pens, I guess, if you will. And so it is what it is. You can't do half of a pre-filled pen. You get the dose that it is. And so you just don't have the flexibility to be able to adjust dosing and really personalize dosing and get those low doses to start with. So you hear about microdosing GLP-1s or just kind of low dose therapy. So let me try and kind of talk about that a little bit. I think the word microdosing kind of gets thrown around a little bit too much. So let me go back here for a second. So let's look at the semaglutide. So I would say, weeks 1 to 4, 0.25 milligrams. That's what I would consider a low dose. And so I have patients that start at that dose and just stay at that dose, right? And if they get benefit and their head feels clear and their body feels better, if they don't want to lose weight and they're comfortable right there, then that's what I would consider a low dose. Microdosing may be as small as 1/10 of standard dosing. And that can be good for really, really sensitive people. Like I started somebody yesterday on Well, it was a quarter of the standard dose, like the lowest standard dose. Um, but here's where it gets tricky. The hard part is getting a small enough amount of the fluid in the insulin syringe. So it's not like an oral supplement or a herb or whatever where you can put one drop in a glass of water and drink one sip of the water. Now, as I said, we have a lot more flexibility with the compounded than the commercial. But the fact remains that, if you're doing a certain potency, like 5 units, it's hard to see less than 5 units. So drawing up less than 5 units and kind of knowing what dose you're getting at a tenth of standard dosing actually gets pretty darn hard from a logistical standpoint. Different compounding pharmacies will have different potencies. So if you can get a lower potency, that helps if you're trying to microdose. But it is a bit tricky at the beginning. So a lot of people that I work with just start at the beginning of the dosing schedule or maybe half of the beginning of the dosing schedule and simply don't increase those increments that I outlined in the last couple of slides. So the commercial versus compounded, I have a couple of patients who do the commercial. So in the beginning, the commercial was really hard to get. It was hard to justify through insurance. You really had to meet certain criteria. I had one patient who met the criteria for type 2 diabetic, but wasn't approved because she didn't have cardiovascular involvement. So, these things change over time, of course, but I like the compounded versions because of firstly, the cost. It's so much more affordable, and the flexibility of the dosing schedules, as opposed to the pre-filled pens where, the dose is what it is and you're stuck with it. So the brand names, typically cash price is like $1,000 plus a month. The compounded works out to about $200 to $400 per month. It depends on which peptide, the potency, the dose, how quickly you go through a bottle. Theoretically, the bottles do expire after 4 weeks once they're opened. So I know for me, I personally feel comfortable stretching mine out to 6, 7, 8 weeks. But the regulation is that theoretically they expire after 4 weeks. So managing side effects, the most common side effects of the GLP-1s are, digestive upset, nausea, constipation, diarrhea, acid reflux. That does happen. And I definitely have patients for whom that's happened. I've had patients who have got sick and had nausea and vomiting and just was like, oh, I want this to work, but I don't think this is going to work. I can't do this. Others that we've had to kind of really go back to the beginning and start at a lower dose and just go a lot slower. And so I have found in those kinds of cases, like if semaglutide creates those kinds of side effects, it's usually worth trying tirzepatide because sometimes that can be better tolerated, even though it is harder to get for us Californians. That's not necessarily true for everybody in the US. So mitigation strategies for that, slow dose titration. Like I said, even if you're at a certain dose for like 8 weeks before you go up to the next, or even if your next dose titration is, a half a step, not a full step. GLP-1 specific probiotics can be helpful. Not always, but I have seen that be helpful a handful of times. The other thing I'm doing more now as I'm learning as I go is BPC 157. And BPC 157 is also a peptide. So it's also a string of amino acids that we have used historically for, any digestive conditions, healing leaky gut, just promoting overall digestive health. So sometimes coupling that peptide with the GLP-1 helps. And then hydration, dietary fiber, of course, to keep the bowels moving. Protein intake is very, very important, not only from a side effect standpoint, but also just in terms of maintaining lean muscle mass. So dietary protein must be very, very intentional. When I say that's a non-starter, like that's an absolute non-negotiable. If you're going to do a GLP-1. Otherwise, you could potentially lose muscle mass along the way, and we don't want that. I would say relatively few patients experience issues like this when dosed carefully, like starting low, starting slow. Again, a patient the other day told me about she'd been on semaglutide a couple of years ago, and the dose that she reported starting at was like crazy for a starting dose, and that wouldn't have been healthy, and that wouldn't have been like part of the recommendation. So yeah, just got to be mindful and careful there. And if in doubt, start low and just build up slowly. And if you are looking to lose weight, it may be a slower road for that, but better be able to tolerate it and keep going with it than, not tolerating it out the gate and either not having fun with digestive side effects or not being able to continue at all. So who are GLP-1s for? Chronically ill patients with metabolic dysregulation, food cravings, inflammation, all kinds of things there that can be applicable to people with chronic illness. I also think patients doing all the right things. I mean, I've seen this so much over the years, and I just, I think it's like the role of chronic pathogens and infections and inflammation on like the hypothalamus and the fat burning regulation, and it just does not do anyone any metabolic favors. So if we're not seeing like weight loss or metabolic improvement, then the GLP-1s can be really, really helpful to kickstart. Patients motivated to improve diet and lifestyle. This is, as with any intervention that can cause weight loss, you don't do this so you can sit on the couch and eat pizza. Like, that's not the point. And so, it really works best in people who are very mindful of, the protein intake, dietary fiber, high water intake, keeping the bowels moving, using magnesium if needed, just kind of doing the right things overall. So it's really not for patients seeking weight loss without lifestyle change. I'm sure there's a lot of people out there in the world of, obesity and diabetes who may be using this and losing weight successfully without lifestyle change, but obviously coming at it from like a naturopathic functional medicine standpoint. That's not the people that I'm working with. Most of the people I'm working with are very motivated to do the right thing. So there's a couple of thyroid cancers. The research on this is mixed, but there are a couple of types of cancers that are cited as contraindications for the GLPs. Caution with a history of pancreatitis. And of course, this is sort of obvious statement. GLPs are not insulin, right? So they don't replace insulin in type 1 diabetics. So a couple of things that I hear, the questions that I get frequently: can I get it if I don't have diabetes? Yes, through compounded pharmacies and prescriptions. It is available now. What if I don't want to lose weight? That's okay. Low dose can target inflammation without major weight loss. So that those two things are not mutually exclusive. Will I lose muscle? Well, yes, if not managed properly. So this is where that protein intake is very, very important, and preferably strength training. Now, in my healthy patients, I'm like, strength training is non-negotiable. So obviously chronically unwell folks, there's a threshold, there's a capacity. Not everybody can do that. I just encourage people to do resistance training or strength training to their personal ability. So what is microdosing? So that's staying at the low doses for non-weight loss benefits. And then we talked about this. Do we have to take it forever? Not necessarily. You can taper down. You can space it out as your metabolism stabilizes. So it's not necessarily a forever thing. So the availability of GLP-1. So this has shaped kind of what we have been able to do with GLP-1s over time. Big Pharma is trying to restrict compounding pharmacies from producing the GLP-1 agonists for injection because that's their wheelhouse, right? They want dominance over that. And so there was a time when some of the brand names, whether it was Ozempic or Wegovy or whatever, don't keep track, but if they were in shortage, then compounding pharmacies were allowed to produce the GLP-1s because they were trying to fulfill a need while there was a shortage commercially. And then when the meds got off the shortage list, the pharmacies were restricted. So we have a pharmacy here local to me in San Diego that I used to get my semaglutide, tirzepatide, and then they got restricted. And so now we use a pharmacy called Strive Pharmacy in Arizona. They actually took on Big Pharma and they won. They won a lawsuit against Big Pharma to be able to produce these compounds. So that was a pretty gutsy move on their part to do that. Probably not inexpensive, but compounding pharmacies, like they're such value to us and they're just getting a harder and harder time. So it's been sad to see over the last few years. And this is just another example. So most of the compounding pharmacies will add like B12 or glycine or something like that. to kind of to their formula to make it unique. And that way they can say it's medically necessary to have B12 to offset the nausea and glycine to help spare muscle degradation or whatever the case may be. You know, they'll kind of state their argument. And sometimes that's enough to help to set it apart from the commercial one and be allowed to produce it. So if our commercial semaglutide tirzepatide goes away, what do we do? And hopefully it won't, and hopefully over time it will just get more widely available. But I definitely had to think through that for a minute when our local pharmacy was stopping to produce them, and before we knew that Strive was going to continue and seems to be successful in continuing. So the pharmacy started making sublingual forms. We have no data on how they work. So I don't know that they ever got off the ground, but, you know, they're obviously trying to find different delivery forms that they could get away with. You know, going to commercial brands like Wegovy or Ozempic or whatever and just doing a cash pay, I mean, that's an option. But spendy, like I know a couple of people spending $1,000 a month to do that. And then there are also research grade peptides, and they're not as closely regulated. There is a company called Peptide Sciences that I do use for some peptides. They're made in the US. They're approved for research purposes. So that would be another option too. I know for myself personally, and everyone's got a different comfort level. For myself personally, if compounded semaglutide went away, I would feel comfortable and safe for myself going to Peptide Sciences and buying semaglutide from them. It just comes as a powder, so it needs to be reconstituted. It's a little bit, you got to, you know, do the math to figure out dosing equivalents, et cetera, et cetera. So long as my compounded is available, that's what I can get for myself and my patients. So long-term strategy can maintain low dose for appetite control and mood stability. Like I said, recommend strength training and high protein intake as non-negotiable parts of success. Just because with any weight loss modality or whatever it is, any weight loss tool, there's a potential for losing muscle mass, right? And the quicker one loses weight, the more potential there is for that. So that's why like just going low and slow over time with the dosing, doing strength training to as much as possible, maintaining the protein intake are all like key factors in that. And then we're emphasizing individualized plans and long-term metabolic health over quick fixes. So I see there's a role for GLP-1s in many, many, many of my patients, regardless of being overweight or wanting to lose weight or not. I think that getting more metabolically healthy is key. And just managing inflammation and chronic illness is such a huge part because it's such a big part of what people experience. All right, so let's go on to Q-Restrain, otherwise known as SOT. I still call it SOT. It's hard to change a name completely. But that's kind of where we're at. So SOT is supportive oligonucleotide therapy. It's a genetic treatment developed by RGCC Labs. And it, like I said, recently renamed Q-Restrain. I'm still going to call it SOT in this webinar. Sorry, RGCC. So it's originally used in Europe for cancer. I mean, they still use it a lot for cancer and for helping with tumors and blood cancers actually. But now it's been adapted for Lyme, co-infections like, the Borrelia itself, Bartonella, Babesia, Ehrlichia, Rickettsia, and also chronic viruses. So you can do SOT for Epstein-Barr, cytomegalovirus, HHV6, etc. Typically, and I won't go off on too much of a tangent, but typically when somebody has tick-borne infections and viruses, we always want to treat the tick-borne infections first. And so I do have some folks that have done like Epstein-Barr and things like that. And if there's time after, if anybody wants me to speak more to that, and just put it in the chat or the Q&A in terms of the order of how we do things, but we always look at tick-borne before viruses. So essentially, this is a gene silencing therapy. So it's blocking the ability of the target organism or the bug to replicate. Okay, so it blocks the biological processes of that target pathogen so that the pathogen cannot replicate. So it's 98% specificity to the target genes. It doesn't affect human cells. And so the goal is to shut down replication of the targeted pathogen by interfering with its ability to reproduce, right? That's the bottom line. We're trying to like snuff out the fire so that these bugs can't reproduce and maintain a foothold in the body. So there's a custom like genetic key made from the patient's blood. So it's matched to the DNA and RNA of the specific strain. I'll talk you through the process, like the logistics of SOT from start to finish. But it's really fascinating because what we're doing is we're sending the patient's blood over to the lab, and the lab is in Greece, and we tell them what our target pathogen is, and it has to be proven by lab work that that is a pathogen that's relevant to that patient. And then they make this remedy, and this remedy is made from the person's blood matched to the DNA of that strain. And so it's very individual and very unique. Like if they sent that remedy back and it got infused into somebody else, it wouldn't work because it's based on that person's blood. And so it's very sophisticated technology in how they're doing that. The actual process and the actual delivery of the treatment is pretty simple. It's like a single IV infusion. And then the SOT circulates up to 6 months in the body, working continuously to block replication. So it's the most active for probably 3 to 4 months, and then it starts, like tapering off at the 4 to 6 month point. But it does have activity in the body for up to 6 months, trying to snuff out that pathogen and the replication of the pathogen. So it's immune neutral, right? It's not anybody else's blood products or not anybody else's DNA. It's like built on your own blood. So you don't expect like allergic reactions or anything like that. It's non-toxic. It's very individualized. It doesn't do anything to monkey with human DNA. We're really looking to mess up the pathogen's DNA is kind of the goal here, not the host's DNA. So it's extremely safe in that respect. So what can we target? I mean, Borrelia, Bartonella, Babesia, Ehrlichia, Anaplasma, Rickettsia, all kinds of viruses, not available for COVID-19. There are some limited species of parasites that can be targeted. Unfortunately, nothing in the fungal Candida mycotoxin realm as targets. That would be really awesome if they did. And like I said, Q-Restrain's been used for cancer. I don't do any cancer treatment, so it's just not something that's on my radar. And there's different protocols for that, but it has historically been used fairly extensively for cancer. So ideal candidates, chronic Lyme and co-infections, definitely more so than our mold population, right? So sometimes, and again, I can talk about this more after if we have time, but sometimes when I'm working with a Lyme mold person, which most of my people are Lyme mold people, I wouldn't treat mold, this is going to hold rabbit hole. I wouldn't treat mold and Lyme at the same time, right? We've gone over that. And part of it is that I feel like we've got to get the mold cleaned up before we can really effectively treat the Lyme. But also, if we're looking at doing antibiotics for Lyme, for example, and we're doing, say, itraconazole as an antifungal in the mold space, you're not going to do itraconazole and then antibiotics. That's going to be like too much on the body, too much on the liver. So in this sense, so long as I know where we're at with mold treatment and that we've got that under control and someone's not in mold, we can do SOT for Lyme and at least be getting something going for the Lyme and the co-infections, right? I know I've had patients who are like, oh, enough with this mold treatment. Like I need to treat Lyme. When am I going to be able to treat Lyme? And so this is a way to kind of like marry them together a little bit more. Obviously, I wouldn't want someone who's like super high mold and living in mold and whatever to get SOT because there is more of a propensity for then having big Herx reactions and mast cell reactions and things like that. But it is kind of nice to have something that we can be running them a little bit tangentially. So good for recurrent or relapsing symptoms despite other therapies. I mean, so a patient of mine has gone through every single therapy for Bartonella, like every single thing you could think of. He's done double dose dapsone protocol, like all the things, and just has this, relapsing Bartonella that's so aggressive. And so did an SOT for Bartonella and like honestly had about 12 months of not symptom free. I'm not saying that, but like functional, like living his life, can manage the rest. And then interestingly, after about 12 months, the Bartonella symptoms started sneaking back in. So we were going to be like, okay, let's hit it again with another SOT. But his comment was like, gosh, if I have to do an SOT for Bartonella once a year for the rest of my life, then, I'm in. Because it was really something that made a difference when nothing else had made a length, an ongoing difference. It's good for high pathogen load with identifiable lab markers. So I've mentioned this before. There must be a positive test for that target pathogen within 6 months of ordering the SOT. Okay, and I'll talk about which labs we use for which in a minute. And then desire for individualized low side effect treatment option. I'm not saying SOT is without its side effects, but it's more like Herxheimer reactions and flaring of other infections. So we'll get there in just a sec. So Q-Restrain SOT remedies are strain specific. So you can't just order a Borrelia SOT, right? It needs to be a Borrelia burgdorferi SOT or a Borrelia afzeli SOT. Now, there have been times, say on an IGeneX panel, where they detect Babesia, for example, but it's listed as Babesia species. Like they couldn't get it down, they couldn't speciate it, they couldn't get it down to the individual species. You can order an SOT based on that. So you can send the blood over. RGCC will try to identify the strain. They'll try and hone it down further to identify the strain. It's a bit of a crapshoot because if they can't identify the strain and can't do the SOT, there's some finances that you're out that you don't get back because they've run the process and done their thing. The ones I've sent over recently in the last few months, they have been able to identify the target. If they do that, you don't find out what the target is, which, at the end of the day, fine, that's fine. So it is possible if it's not speciated, it's not ideal. There's a little bit of a risk involved in terms of like the financial elements. But I've had some, knock on wood, I've had some good results with that, some good outcomes. So yeah, if it's like Bartonella species on IGeneX. Now with Vibrant, they do speciate things a lot, like in more detail. So that's kind of why we use Vibrant for SOT testing. But if somebody has IGeneX, and sometimes on IGeneX, they'll be able to show it's Bartonella henselae or Bartonella quintana. So that's great. It's very specific. We know to order that target, but sometimes we don't get that. So symptoms plus labs equals the target selection. So if people have multiple co-infections, then we have to sit down and figure out what's the most important thing to do. So that's based on symptoms, like that individual with like raging Bartonella symptoms, like it would make sense that would be where we would start. I don't believe, I read some places online, oh, you have to do Bartonella first, or I don't believe that to be true necessarily. For me, and this has been true for years in antibiotic protocols also, it's like, what's the dominant infection? Like what do we really need to get a handle on here? So pre-treatment requirements must have a positive lab result for the target infection within the past 6 months. We actually have to submit that as the ordering provider to RGCC with the order. So Vibrant America, IGeneX, DNA Connections, Galaxy, like whatever. And, frankly, LabCorp too, we just are less likely to find it. But they do accept all of the kind of the Lyme labs. So Vibrant tick-borne 1.0 or 2.0 panels are ideal for strain-specific identification. The 2.0, the 1.0 has all the tick-borne stuff. The 2.0 just adds a lot more of the viral elements. So just looking at tick-borne, the 1.0 is adequate for that. And so that's kind of would be what I would consider a first kind of stop specific to SOT. And then the patient's blood must have been received at the lab within the last 6 months of that test. So then we draw blood, send it over to Greece. 1 vial of blood is typically enough for 2 to 3 targets. So you can order, a Borrelia burgdorferi, a Babesia microti, a Bartonella henselae. Like so long as you've got the lab positive within 6 months, you can order multiple SOTs at once. You're not going to infuse them all at once, but you can order them at once just to save time, like only sending blood once. And there's some restrictions on being off certain things before that blood draw and before the infusion that we'll get to. A maximum of 9 Q-Restrains are allowed in a 12-month period. And this is all RGCC guidelines. maximum of 4 Q-Restrains for the same target are allowed in a 12-month period, spaced at a minimum of 3 months apart. Now, I wouldn't do that for tick-borne pathogens. There is some evidence that for Epstein-Barr and some of those viruses, like Epstein-Barr could take 2 or 3 or 4 SOTs just for it, whereas the tick-borne, we don't think of it as doing 3 or 4 of the same pathogen. We think of, we do one and then regroup and see what our results were. And then if anything, move on to a different target, not necessarily repeat that same target. If you're repeating the same target, the lab does require updated test results showing the pathogen still present. And I've got multiple lab results where after an SOT, the blood went from positive on labs to negative on labs. So yeah, it's kind of interesting. So step by step. So consult with me first. Person comes in, we review their labs, review their symptoms. If we have enough data to decide which infection to target first, if we need labs, we'll order a Vibrant tick-borne. Now, if you've heard me talk before about labs, I'm not a huge Vibrant fan. It's not my favorite. I have a bit of an issue with it because for initial Lyme diagnosis, I feel they set the bar too low. And it kind of comes in looking like everybody has Lyme, or potentially everybody has Lyme. And we want people to be, the problem in the Lyme world for years has been like misdiagnosis, missing the diagnosis. So we don't want to miss it, but we don't want to then over, diagnose too. But that precise reason is why it's good for SOT, because even if somebody's just a very low, like intermediate, so Vibrant, like 1 to 10 is low, or what I would consider negative, 11 to 20 is moderate, what I would consider indeterminate, and then 20 and above is high, what I would consider positive. So I had a patient the other day, or a few weeks ago, where we'd been trying for months to get a positive on Babesia because she has Babesia symptoms. We're treating her with Babesia meds. They were helping. Like, it's so clear. But we couldn't find it. Like, we did the Babesia panel on IGeneX. It didn't show up. It didn't show up on MDL. Like, we were looking and looking. So on Vibrant, it was a 10.5 for Babesia microti, which is barely in the moderate range. But that's enough for our GCC. And so we're like, great, we'll take it, So with Vibrant, everything has to be very much put in clinical context. But for that reason, and because they do speciate everything, there's no like, oh, it's Babesia, but we can't tell the species. Like, that won't happen on Vibrant. So for that reason, we do use it for SOT purposes. So 2 weeks off antimicrobials before the blood draw for the SOT itself, not before the blood draw for the lab testing. So if you're getting a Vibrant test and you're on antimicrobials, antibiotics, herbs, whatever, doing ozone, no problem. It's 2 weeks before the blood draw for the SOT. Now, when I say antimicrobials, I mean everything. Antivirals, antifungals, ozone therapy, high dose vitamin C, like IVC, even methylene blue. Like, so even if you're doing an SOT for Babesia, which is actually a protozoa, you still need to be off antimicrobials, even if it's an antifungal medication, right? So anything that's going to impact like the pathogen load in the body, because they actually want that signal to be more lit up so that they can find it, target it, create the SOT for it, and make it an effective treatment. So the rule is 2 weeks off all antimicrobials before the blood draw to go to Greece, and also before the infusion itself. And that can be hard for people. Like, there are people who are really, they get more symptomatic off their antimicrobials. So it is one of the challenging parts of SOT, but it just is what it is. You can stay on supportive supplements, detox helpers, binders, etc., etc. So then the next step is the blood draw for the SOT. It gets sent to RGCC in Greece. Typically about a month, 4 to 6 weeks, I'd say, to have it shipped back, to get it to RGC. They manufacture the Q-Restrain and then ship it back. And then once again, 2 weeks off antimicrobials before the infusion. The infusion itself, we allow 60 minutes. It doesn't usually take that long. There's a little bit of a dexamethasone, a very small steroid dose, just to improve the vein absorption and get the SOT in there and doing its thing. It's not like a high dose steroid. It's just a very small amount being administered. Famotidine we often give for more histamine prone patients. And important, don't do any other therapies on the day of the infusion. So I usually have people like not even do their supplements or whatever. And then for 1 week after the infusion, you have to stay off antimicrobials. And then you can resume whatever antimicrobials you had in place. Now, the RGCC folks would say they actually prefer not to be doing treatment for the pathogen that's being targeted. They say just, get out of its way, let the SOT get in and do its thing. But say you've just done a Bartonella SOT and want to get back on fluconazole or something like that, then that's fine after a week. So how many are needed? Each SOT targets only one species. So if you do have Bartonella henselae and Bartonella quintana, then you would want to look at doing two SOTs, two separate SOTs. That one patient that I was talking about with the Babesia, interestingly, so we did Borrelia for her. She had improvement with it. No big deal. Didn't have a big herx, didn't have a big reaction, was having improvement with that. Then did Bartonella henselae next, had a fairly significant herx. And there was a couple of other potential medication side effect question marks in there as well. But interestingly, what we looked at after that was when we retested, Bartonella henselae had turned negative, but Bartonella quintana was super high, and Bartonella quintana was negative before. So I do see this sometimes, that if you go after a specific target, it can allow other infections to kind of, rear up. It's not to say you have to go in and do SOTs for everything, but you may have to go in and treat, whether it's antibiotics or ozone or rife or whatever it is. You may have to go in and squish that down. So that's where there's a lot of discernment of, okay, is this herxing from the SOT I just had, or could it be that something else has kind of taken advantage of the situation and is flaring up? And that's why we won't do any more frequently than one SOT per month. The RGCC regulations say no more than every 3 weeks. I've heard of clinics doing them weekly, and I really don't agree with that, because you just don't get enough time to, see if a patient's going to flare. What's that going to look like? Let's let that die down before we introduce the next one. And so I just think it's just too much all in a short space of time. So we talked about that. So I would say if we're repeating an SOT for the same infection, I wouldn't do it less. Certainly not less than 4 months, usually more like 6 months, but we don't always see that's necessary. So what to expect after the SOT infusion? So common responses: mild headache, fatigue, flu-like symptoms. Herx reactions can happen for sure. I have seen some mast cell flares more recently. I didn't really see that before, but I've had a couple recently that I'm like, oh yeah, okay. Need to be mindful of that and try and control mast cell going into the process. These were all people who'd had mast cell, not all, there's like 2 lately, but these are people who'd had struggles with mast cell over time. So it's not like it really triggers it out of the clear blue sky. But I am recognizing that more as I look at some of the information on mast cell. Flare-ups of other infections, which is what I was just talking about, once one is suppressed. And for some patients, they notice symptom relief within weeks. Others, it can be a couple of months. So that's where not loading too many things in too short of a time span, I think, is really important. And then supportive care is essential. Detox, binders, glutathione, drainage, castor oil packs, sauna, hydration, like all the things to help the body so that if there is some flare or some Herxheimer reaction, then it's better equipped to manage that, just as would be the case with any new modality being introduced. So retesting typically 3 to 6 months after the infusion, sometimes sooner if we're looking at like, okay, we need to retest to make decisions about what to do next. RGCC recommends retesting if pursuing additional targets or if clinical change is unclear. So yeah, if you've done an SOT or 2 SOTs and then it's a little bit of a mixed picture and we're trying to figure it out, then obviously retesting is one of the tools that we have to be able to track those things. Expected outcomes. So this is from RGCC labs. In viral affected patients, a positive clinical outcome reached 91%. And in Lyme disease, approximately 95% of cases had a positive clinical outcome. I will say, and quite honestly, that the majority of our folks that do SOT do have positive outcomes. Is there one thing that we were saying earlier? Is there one thing that's the be all and end all for everybody? No, of course there isn't. I wish there was. Everybody would do it and we wouldn't have to worry about Lyme anymore. But the majority of the time, people have improvement. They're having benefit from it. They want to come back and do other co-infections because they're kind of on this positive roll and they want to like sort of see the job out. But because the targets are so specific, multiple SOTs may be necessary to address co-infections to get optimal results. So I say that to my patients going in, like, it's not an inexpensive therapy. So if you have multiple co-infections, I wouldn't expect us to go in and do one SOT and like be able to call it good necessarily. If you have one infection that's absolutely your dominant and that's your biggest thing and you just want to go hit that one first and see what you're left with after, then sure, by all means. But I try to have people have the expectation of maybe needing 3 or 4 to get optimal results. So summary, the infusion itself is very safe. There's no allergic reactions recorded. We have not had, problems with the actual process of the infusion. As with anything, works best with paired with a holistic approach, detox, helping, nervous system support, other antimicrobials potentially, just not in those windows, right? 2 weeks before and then 1 week after the infusion. We found it to be a powerful tool. And I love that I'm doing less antibiotic prescribing these days. Like people are moving away from standard antibiotic protocols and like leaning more into SOT as a way to deal with their tick-borne infections. And then encourage for use in cases of co-infection overlap, treatment plateaus, or immune fatigue. So a lot of people that I'm working with, they've done all kinds of treatments for Lyme and tick-borne infections over the years. Their immune system may be, sluggish. They've got multiple co-infections. It's just hard to get on top of that. And so sort of a systemic SOT regimen can be really helpful. So a couple of just final general thoughts about everything we've talked about tonight and in the first webinar is, integrating into clinical protocols. These things have to be personalized, right? There's no one size fits all. Like who's going to be a better candidate for SOT therapy for their tick-borne infections? Who's going to benefit from LDN? Who's going to really their life is going to be changed by GLP-1s? It's got to be individualized and personalized. So there's no cookie cutter approach. There's no one protocol that fits for everybody. So that's where it's really important to have this kind of strategically put together for each person. Timing matters, when to add these to the treatment. Like when do you prioritize doing more immune regulation versus going in and trying to knock out the pathogens? When do you really focus on doing mold treatment before even getting to SOT? Like these are all questions that it's got to be a strategy. It's like a game of chess, right? You kind of know where you want to be a few moves ahead, but you've got to adapt along the way. And so we don't do multiple things. We don't start multiple things all at once. We start one thing at a time so that we can then, assess, reassess, make the next decision. We layer medications and modalities based on tolerance and priorities. Obviously different people have different level of sensitivity and different things that they need to work on in their health. And so that will shape kind of how we do some of these things as well. As always, and I didn't talk about this much, especially in the antibiotic in the first webinar, I didn't really talk about it. And I just kind of said would be here all night if, that's a separate whole conversation, but working on detox and drainage, working on mast cell support, addressing mold toxicity. They're such important things as part of a comprehensive plan. So none of the things that I've talked about are like standalone. They're all done within the context of, a bigger, more integrative plan. And then always integrate mindset, lifestyle, foundational support, sleep, exercise, getting out in nature. All those kinds of things make a big difference as well. So that's truly what a holistic approach then looks like. So that is the information I have to share. I'm going to stop sharing my screen here and just see if we have any questions or any comments in the chat. No. Oh, look at that. All right. Everyone's tired. We went a little over time, so thank you for hanging in there. All right. Well, excellent. So, yeah, if you want to get in touch, you can reach out to our clinic at restoremedicine.com, restore without an E on the end. So it's RESTOR medicine.com. Oh, I have one question here. What was it? What's the average price for an SOT? So every clinic is going to be different. At the current time, our clinic is $2,500 per SOT. And I think we're on the less expensive side. So there is a variation between different clinics. So I can't speak for anyone else. I can only speak for us, and we're $2,500 per SOT. And that covers the lab testing, being shipped to Greece, the remedy being made and being infused in our clinic. And you can get the blood drawn for the SOT anywhere. So the SOT, we have a kit. And once the SOT is ordered, we ship the kit to our patient, and then they can go locally to get the blood drawn. There's nothing really fancy about the blood draw for the SOT. It's not like a difficult, weird tubes or any weird requirements. It's pretty straightforward. All the instructions are in there. So yeah, so that's how that works. All right. Well, thank you so much for joining. Yeah, share this webinar, share this video if you have people that you know in your circles with chronic Lyme. We've got to get more information out about some of these more advanced and more integrative therapies. So yeah, I hope you enjoy the rest of your day, and I'll see you again very soon. Okay, bye.